Good morning, good afternoon, good evening, wherever you are when you're watching this. This is Howard Goldman from Cleveland, Ohio, Cleveland Clinic, and I'm very happy that you've joined us for this industry theater about macroplastique, tried and true. Dr. Abbas Shoberi, who's from Innova Women's Hospital, will be working on this together with me. And what we'd like to do is really just take you through some of our thoughts and some of the data on why really macroplastique is our injectable of choice at this point. As you can see, I'm from Cleveland, Ohio, and I'm glad you're with us.
So I will be presenting the next case, and this is a 60-year-old woman, no prior surgeries, comes with stress urinary incontinence for the past year. She doesn't have any prolapse on physical examination, and she does have a positive stress test. Post-void residual is 30. All of our patients that come in, we generally have them do a Euroflow if they have urinary issues, and she had a normal flow pattern. On examination, the Q-tip testing is she doesn't have hypermobility. And we did do a urodynamics testing with low leak point pressure because, mainly because when she exerted herself, as we were examining her with the slightest exertion, she was leaking. And we were really interested in knowing how low her pressures were. So, Goldman, how would you manage this patient?
So, you know, the guidelines say try pelvic floor therapy, and we can certainly try that. I have a feeling it's not going to work with such a low leak point pressure. I doubt it'll work. I would really talk to her about macroplastique versus a retropubic sling, retropubic synthetic sling. I think the retropubic or all the mid-urethral slings work better in patients who do have some mobility. So I would quote her a lower success rate than what I usually quote. But I think it certainly is an option. On the other hand, macroplastique or a bulking agent would be perfect. This is sort of the ideal patient for a bulking agent.
I agree. So this patient underwent macroplastic injection, as we discussed, and she did quite well at the follow-up examination, was able to empty her bladder, and she was dry. And we also did an ultrasound on her, as you can see here. This comes from one of our publications, and you can see, just to orient the audience here, so this is, I'm going to draw here, this is her pubic symphysis. The transducer is inside the vagina here. So we are looking anteriorly, and we can see the urethra is drawn here in this line. The patient's bladder is up here. And then we can see her macroplastic is nicely applied all around the urethra. Actually, when we look at it, you can see that it's to the left and right and also circumferential. So this is a nice application of macroplastic for a primary patient with incontinence, and this is her ultrasound.
So tell me more about the ultrasound, because I don't use ultrasound at all for any of these patients. Is this something you're just doing for academic interest and teaching, or is this something that's you think is necessary?
So whether you have, whether you do ultrasound or not, it has to do with the availability and your skill level. For this case, we are presenting it for educational and research purposes and for the audience to know where the macroplastic goes and what it does. And for us, it has been impressive in terms of the fact that when we image patients with macroplastic versus the other type of bulking agents, macroplastic seem to have a more reliable application in terms of where it's supposed to go. And we'll show that in some other cases as well.
So I would take from what you just said that ultrasound probably not necessary to do when you're doing these, but from an academic standpoint, it actually is very nice because it seems to confirm that this bulking agent is more likely to be where you would expect it to be than perhaps others.
Absolutely. So in these lectures and with the video demonstrations and the cases that we have presented, we have presented the long-term track record over the past 20 years that macroplastic has. And we have also talked about multiple studies that show the safety and efficacy of macroplastic injections. Macroplastic has more studies and more rigorous sample sizes than the other agents that are on the market, the bulking agents that are on the market. We view it as a minimally invasive procedure that can also be performed in the office, has very low adverse event rate. As I said, in my mind, when I say adverse event is either a patient being incontinent or not being able to void, nothing more serious than that. And then it just demonstrates significant improvement rate for the patients. And again, in my hands and Howard's hand, if you have appropriate selection, the patient should have very good outcome.
With that, on behalf of Dr. Shaberi and myself, I really want to thank the ICS for giving us this opportunity to have this discussion. I want to thank Library for sponsoring this. And I'd like to wish all the attendees of the ICS, I hope you had or are having a good meeting. All the best. Thank you.
Thank you.